So today our plan of discussion is going to be the syndromes with cardiac manifestations or cardiac lesions. Okay, now give me a second. Okay, yes. Now basically those who are new to this, please note this is going to be an advanced discussion. Don't get panicked by seeing the level of this discussion, because your basic lectures on all these lesions, it's covered in the basic lectures section. Okay, you can refer back anytime and finish it off. This is going to be an advanced discussion. You will come to know what actually advanced discussion is. And this is a very important part of your current NEET MDS pattern, because the level of clinical questions, the level of application level questions are increasing every year. So this is that. Okay, and it is going to be, connecting. Okay, as I've told you yesterday, if those who were there, it's going to connect different lesions. So it is not a chapter wise. Okay, you can see the name itself, syndromes with cardiac manifestations. So it's not going to be in the same chapter. And I told you yesterday, just a quick review, we're going to discuss these lesions. Okay, the Marfan syndrome, which is in a disorder of elastin, Ehlers-Danlos syndrome, majorly, which is a disorder of collagen, and osteogenesis imperfecta, a little bit, majorly oval pathology lesion. Again, the clinical level of it, which is a disorder of collagen. Then we will see two autosomal disorders, Downs and DiGeorge syndrome, which is related. One is trisomy 21, the other is deletion of a segment of 22. Then sex chromosomal Klinefelter-Sternus. Now, it's not limited to this. That's what I said to you. Anything connected to it. For example, you will see eye lesions in Marfan syndrome. So we'll connect this with pemphigus and pemphigoid, which also has got some eye lesions. Gardner syndrome has got, I don't know how many of you know it, has got some eye lesions. So we'll connect like that. Okay, it will be just a connection to just for you to arrive at the right answer and identify the key points. Again, my purpose of this discussion is going to be to make you understand the or to make you identify the key points. Okay, any question if you want to answer, you need to identify the key phrase, key point, whatever you call it by name, but that is the key. Okay, now once again, I'm going to go to the basics of your heart murmurs. Okay, which is this is very, very, very important to understand. So once again, a quick repeat. So as I've told you yesterday, there is going to be diastolic murmurs. Okay, there's going to be diastolic murmurs and there is going to be systolic murmurs, isn't it? Systolic murmurs. So once again, let me repeat, the pathophysiology, clinical features, everything is there in the basic lectures section. This is just to one thing is to give you a trick to learn this, those who have not listened to this. And second thing is a quick review. Okay, now diastolic murmurs, I told you the short form you have to remember here is DSV. That is, diastolic murmurs are seen in, the S is for the stenosis of valves. Okay, once you know this, we just need to substitute the terms there. So if it is seen in the stenosis of the valves, it is also seen in, I'll use another color, it is also seen in the regurgitation. Okay, there are two conditions, stenosis and regurgitations. So it is also seen in regurgitation. So opposite of stenosis is regurgitation of the major vessels or great vessels, whatever you call it, major vessels. So what are two valves? Mitral and bicuspid is simple way. Bicuspid and tricuspid, or mitral and tricuspid. Mitral is bicuspid. And what are two major vessels? Aortic and pulmonary. So these are the two conditions you see it. Okay, those who don't know, I'll give you the names in detail. So then you substitute it again. So once you know this is super easy, super duper easy. Okay, so yeah, the first condition, the seen in that is diastolic murmurs in the stenosis of the vessels is what I said you. So the stenosis, so it's going to be two conditions, two stenosis. So second letter is going to be stenosis. What is the first letter? Valves. So it is mitral stenosis and tricuspid stenosis. Two valves. Very simple. Okay. Now, regurgitation of the major vessels. So what are the two major vessels? Again, two conditions are there, and it is regurgitation. So the second letter is always R, regurgitation. And the major vessels are aorta and pulmonary. So aortic regurgitation and pulmonary regurgitation, isn't it? Now, as I've told you, if you want to remember exactly at what period it is, then you start with M, mid diastolic murmur. This is also mid diastolic murmur, that is tricuspid stenosis. Also, you get the mid diastolic murmur. Then you go back, as I've told you, this is early diastolic murmur. This is also early diastolic murmur. Stenosis of the vessel. Stenosis of the vessel. So yeah, stenosis of the vessel and regurgitation. Exactly opposite of this, the first one. Stenosis of the valves, it was there. Here it is stenosis of the vessel. Now you have got instead of regurgitation of the vessel, we have the regurgitation of valves. Okay, so now it is easy, no issues, I think. Let's see, let's apply this. Stenosis of the vessel. So the second letter is always stenosis, stenosis. Okay, aortic stenosis, pulmonary, because it's vessel. Okay, now regurgitation again of the valves. So the second letter is regurgitation, regurgitation of the valve. So mitral regurgitation, tricuspid regurgitation. Right, yes. So coming back, so aortic stenosis, as I've told you, it should be ejection systolic murmur. Okay, aortic stenosis is ejection systolic. Pulmonary stenosis is mid. The other one is all are pansystolic. And I told you, besides MR and TR, we also have MVP, mitral valve prolapse, rheumatic fever, and ventricular septal defect. Three conditions more you have to learn here. Okay. Yeah, regurgitation of the valve. Yes, who was there? Supriya. Yes, exactly. Regurgitation of the valve. So actually, you should just shift this one side. Okay. This is stenosis of the valve. You make it. Okay. This is the easiest way I'll tell you. This is stenosis of the wait. This is the stenosis of valves. This is stenosis of the vessel. This is regurgitation of the vessels, regurgitation of the valves. Okay. And one more thing I just want to add here. Let me see if I can add with a particular color. Which color will I use? Okay. Basically, there are two more murmurs. Austin Flint murmur, which is a diastolic murmur. Okay. Austin Flint murmur. I hope you have seen this. We have discussed this in the lectures. It's a diastolic murmur and aortic regurgitation. Write it separately. Okay, it's a diastolic murmur and aortic regurgitation. There is one more murmur which is seen in the pulmonary regurgitation. So I'll use another color here. Okay, pulmonary regurgitation. There is Graham-Steele murmur. I'm not going to detail. Graham-Steele murmur in pulmonary regurgitation and pulmonary hypertension. This has been a question. Graham-Steele murmur is seen in pulmonary regurgitation. So two murmurs additionally, Austin Flint in AR and Graham-Steele in PR. Okay. So I hope, okay, we've discussed this yesterday. So that's it. Let's come to the question. I know all of you are very eagerly waiting for the questions here. So let's start. Quickly answer. I'll not be waiting too much because this is something which we have even put it in the WhatsApp group for you to answer it. So which of the following is characterized by pansystolic murmur, dilated aortic arch, and irregular pulse? One disease. Okay, pansystolic murmur. You know it very, very clearly now. Okay, it is Marfan syndrome. I'll come to that. We have to discuss a little bit detail on Marfan syndrome. But then what is the key here? What is the most important cardiac feature of Marfan syndrome? Anyone? Mitral regurgitation and mitral valve prolapse, MR. Mitral regurgitation, I told you, we made a right mistake there. Mitral regurgitation is the key here as the pansystolic murmur. Okay, another very, very, very important cardiac manifestation of, I'll come to basics of why this is happening. Basically, the problem is an elastin. And you know that elastin is an elastic structural protein which gives elasticity to the vessels, even vessels, skin, everything. So all these blood vessels are lined by this particular elastin. So understandably, you have this problem. So dilated aortic arch, which gives further complications, I'll tell you that, and irregular pulse. Now, this is not a very specific, this is related to your atrial fibrillation, which is very common again in your Marfan syndrome. Okay, and please note one point I just want you to note here is rheumatic fever. Also, we saw that there is pansystolic murmur, isn't it? I told you pansystolic is, but then they don't have what? They don't have dilated aortic arch. They don't have irregular pulse, and more importantly, it's a kind of an infection. Okay, so it's a kind of a different features in it in itself. Okay, so and aortic stenosis, what is it? What is the problem? What is a murmur associated with aortic stenosis? Anyone? Which systolic? Ejection. I told you, aortic stenosis is ejection systolic. It is not pansystolic. Now, again, ejection systolic is throughout the ejection phase. Okay, but then that's the name. It's not pansystolic, definitely. So pansystolic, what is systolic only? Ejection systolic, again, it's a kind of similar, but then, yeah. ANCA vasculitis, just to know, ANCA vasculitis is an autoimmune disease. Okay, autoimmune disease, which is affecting your smaller vessels. Okay, autoimmune disease affecting your smaller vessels. So not the larger cardiac vessels or cardiovascular manifestations are very little. It is basically localized vascular manifestations. So you don't get this big murmurs and all this. Okay. So let's come to a little bit on your Marfan syndrome. The first thing which you have to note here, you have to know here is it's an autoimmune, sorry, not autoimmune, autoimmune is ANC. It is autosomal dominant condition. Okay, it's an autosomal dominant condition affecting 15th chromosome, the Q. Okay, the Q, what do you call? The smaller Q arm, isn't it? Q and P arm. So, no, P is smaller. So, P smaller, Q, the larger arm. So, it's the 15q chromosome, basically. And due to that effect, what you get? You get a problem with a particular fibrillin, a protein called a fibrillin. Okay, mutation in this fibrillin gene, the gene which produces fibrillin. Now, what is the importance of fibrillin? Fibrillin is a scaffolding, so it covers the scaffolds your elastin. As I've told you, this elastin is there everywhere. It is there in the skin, it's there in the ligaments, it's there in the blood vessels, it's there in the aorta, everywhere. So all these manifestations are affected. So basically, fibrillin, that's one question. Fibrillin 1 gene. So they'll confuse you. Fibrillin 1, 2, 3. It's basically fibrillin 1 gene. Okay, fibrillin 1 gene. That's a basic thing. Now, one thing, okay, this is basically, yeah, this is what is the, okay. I'll do one thing. I'll first discuss the points. Marfan syndrome. There's a picture also. I'll show you that. Okay, yeah, we'll discuss here. So basically, this is what is your aortic dilation, and so basically, this is your dilation of the aorta. Okay, how your aorta dilates, and a little bit more dilation is called aneurysm. Okay, aneurysm is nothing but dilation of your aorta. And then once you're, I'll give more details on this. Once there is a break in the layers, you know, there are different layers, intima, media, externa. So once there's a break, it's called aortic dissection, and this leads to death of the patient. Once that is, you know, aorta is dissected, dissection means broken. So it becomes weak. Okay, by dilatation, it becomes weak, degeneration and all. We'll come to that. I just saw this picture. I want to explain this. So that was fibrillin 1 gene being affected, as what I said. Now there are some features which you have to know. How many of you know the short form of the features of Marfan syndrome, the key features? Easiest, it's to learn. Marfan's only. Okay, so M is for most important mitral regurgitation or mitral valve prolapse. Okay, then A for aortic aneurysm. I told you aortic aneurysm, which finally leads to aortic dissection, which we saw. Okay, aneurysm and dissection. Please note an additional point here. This aortic aneurysm, this dissection, all those are seen in Ehlers-Danlos, which is actually a problem with collagen. I told you. Okay, and one more, the tertiary. Okay, yeah, tertiary stage of syphilis. Just an add-on point. See, one thing I just want to advise you here. Now you are learning these points here and you're connecting it. Your basics you're learning as syphilis, infections, isn't it? Infections in microbiology. But then once you learn that, you connect it to it. For example, next we're going to go for microbiology. You learn syphilis. You'll learn details on syphilis. Okay, so once you learn that, you connect it, or now you learn it, you connect it. It's not like you're going to learn everything about syphilis now. That is not the way. Just need to connect some features, but then your basics has to be in a very systematic way. Okay, don't in a wrong methodology. So that is about it. Now R, what is R? Retinal detachment. Okay, I should be using the blue color only. Retina gets detached. Okay, retina is a very important layer for your vision, isn't it? It's get detached. You're going to see some retinal problems associated with some other lesions also later on. And then we have got this, just for a mnemonics perspective, it's freely movable joints. Okay, freely movable joints or hyperextensive joints. Another point to note here is fibrillin 1 gene. So 2F is there here. Okay, I'll just use a different color so that you don't. Okay. So that is fibrillin gene. A is for arachnodactyly. Arachnodactyly. I can connect it to many lesions here, but I don't want to confuse you. Anyone knows any lesion which is related to arachnodactyly? Oral pathology. Arachnodactyly is like long and slender fingers. Okay, very long. Basically, these patients are, so that is this is next short form, 9 feet height. Just to remember, it's not the exact 9 feet height, but it's a very long patient. So arachnodactyly. Next is subluxation. Okay, not TMJ. We'll see subluxation of TMJ in another lesion. The subluxation or dislocation of your lens. Okay, they can use two terms: dislocation or subluxation of lens of your eye. I'll show you a picture of that lens being displaced into your anterior chambers of the eye. So retina. Okay, I think there's a picture there. Later I'll show you, no problem. Retina gets, no one knows, no problem, we'll study that. Retina gets detached, okay, and your lens also gets detached. This particular detachment has got a specific term and very important diagnosis, which is called ectopia lentis. Okay, ectopia lentis. So these are the key terms here. Okay, and death in these patients. Okay, death in patients with Ehlers-Danlos, death in patients with Marfan syndrome, all occurs basically due to aortic dissection. Okay, aortic dissection, we'll come to that. So this is the major features. Now, a little bit more, I just want, okay, this is the picture, very long patient, okay, very tall patient, in fact, eye problems. What was that? Ectopia lentis and detachment of the retina. Okay, abnormal chest and things I'll show you. Short torso, this area is very short, tall, thin, long. Okay, basically it's a long patient. Okay, I'll show you another question there. Okay, same thing. Yeah, so basically it's a chromosome number 15. Okay, so anyone remembers any lesions we studied in general pathology which is associated with chromosome number 15? Let this be a discussion, isn't it? Marfan syndrome is definitely, so I'll just put it as a map of 15th chromosome. What are the lesions? Someone please tell me quickly. M is for Marfan's. I'll give you a clue. They are the lesions associated with genomic imprinting. No revision. Genomic imprinting. One is starting with A and second is starting with P. Those have not learned, don't worry. Two lesions only, I think, we studied in genomic imprinting. Two diseases. What are they? Parvati, Manju. I hope you were there. For general pathology. Revision is the key. Okay, revision has to be. Not there, Manju, Parvati. Anyone was there? Or those who were there got tired and stopped? This is what happens, you know. This is what I was saying. You majority, what happens is that they think I am not able to learn things. They are not waiting. They are not persisting. That will happen. That would have happened for them. Okay, it is not Patau syndrome, or I'll give it. It is Angelman syndrome. Angelman syndrome, and P for Prader-Willi syndrome. If you have not learned, we'll learn this in detail and what it is exactly. It is associated with just right genomic imprinting. Both this, not all, these two. Okay, these two are associated with genomic imprinting. What genomic imprinting is basically what happens here is the paternal allele gets deleted. Here the maternal mother's allele get deleted. So both of them will have a different symptom. That's called genomic imprinting on the 15th chromosome. All these are problems associated with 15th chromosome. Okay, so just three disease map. Okay, Marfan's, Angelman, Prader-Willis. Okay, so let's go to the next part. Okay, now a little bit more on your Marfan syndrome on diagnosis. Okay, we said one of the most important lesions is eye lesions, ectopia lentis and retinal detachment. So to check for the eye, you do something known as slit lamp test. We do this in one of the oral pathology lesion also. What is that? Slit lamp examination. Anyone? Jokeren syndrome. Okay. Now, that is one test. Now, second thing is you do echo. Okay, and all those things to identify the murmurs and everything. You know it. Now, there is a very, very, very important criteria known as GENS criteria or international GENS criteria, where you have got some major criteria and minor criteria. I'm going to discuss the major criteria. Minor, all those you have learned. Lots of things are there. Okay, forget about it. It will never end. It is non-ending. Okay. Did we miss anything? No. Yeah, it's all fine. Yeah, one small area is there. I'll come to that. Those are the major criteria. So basically, we all said the major criteria, one of the major lesion is your skeletal abnormalities. And the patient is very tall and all those things. So any four, okay, please note, any four skeletal abnormalities. Okay, whatever it is, long fingers, arachnodactyly, whatever it is. But then two terms are there which you should be aware about. It is called pectus carinatum. Okay, pectus carinatum and pectus, okay, little complicated, excavatum. So what is excavatum? Excavated, sunken, gone inside. Carinatum is protruding. So basically, pectus is something related to your chest. So carinatum is something where your chest, the patient's chest is protruding. Okay, protruding. I'll show you the pic. Excavatum is sunken inside. So these two are among the major criteria. Where is that? Okay, this is it. This is a sunken excavatum. This is protruding. See this. Okay, so just that's one of the major criteria. Now, second major criteria, we already said it is ectopia lentis. The lens gets displaced or dislocated, ectopia lentis. Third is your aortic dilatation. That's a very important, okay, dilatation or aneurysm or dissection, whatever you see it. And finally, one more, which we have been said is dural ectasia. There's a term there. So basically, it's a dural. You know what is okay? Dural ectasia, to be very specific, of spinal cord. Spinal cord. Now, basically, you know that there is meninges in the around the brain. There is also meninges in the spinal cord that has got a covering called the dura, arachnoid and pia, isn't it? So this dura gets enlarged. That's called dural ectasia. That's it. The dural sac gets enlarged. That's called dural ectasia. And that these are the four major criteria. That is skeletal, NE4, ectopia lentis, aortic dilatation, dural ectasia. So if any of those four is there, it is being considered to be the major, fulfilling the major criteria. I think that's it. So this is the basic understanding of your Marfan syndrome. Okay, what's the answer for this? Quickly, all the characteristics of Marfan syndrome except. Okay, you confused between a high arched palate or high arched foot, isn't it? Actually, okay, there is highlighted also. The answer is exception is a high arched foot, which is not a feature. Now, can anyone tell me any other lesion which is associated with high arched palate, even cleft lip and palate also associated with that? High arched palate, just give me two lesions. This is how advanced discussion will go. It is actually conditions associated with premature closure of your, exactly, very good. Who is that? Cleidocranial dysplasia. Cleidocranial dysplasia. One more is Krausen syndrome. Both of this you have high arched palate. One very typical lesion, Mahvesh, which is associated with cleidocranial. Very typical. Absent of a particular bone, anyone. A particular bone is missing in this patient and they can bring their shoulders closer. What is that bone missing there? Exactly, clavicle. Yes, clavicle, exactly. Just to know that, just to connect, high arch palate. Okay, let's see to the next. Anything I'm missing out? Okay. Okay, very simple. Now this is where you learn it, you forget it. Is it fibrillin 1? Is it fibrillin 2? What is the answer? Fibrillin 1 or 2? No, you this is what you call it as, this will be a terrifying thing. You have learned everything about Marfan syndrome. Be very careful on this part. Okay, you have learned everything about Marfan syndrome. One thing you forgot is 1 or 2, because you learned collagen 1 is there, collagen 3 is there, different 1, 2, 3 is there. So it is actually fibrillin 1, don't forget. Okay. Okay, this is another very important question. Cystic medial necrosis. Don't always jump onto one particular syndrome if you're learning that. You're going to shift it. Cystic medial necrosis. What is that? You have your blood vessel, okay, which has got 3 layers. Outer layer is called adventitia, the middle layer is called media, and the inner layer is called intima. Okay, and this within that is your flow of blood which is happening inside this. What's the answer? Answer me. Okay, I'm just saying this. If you know the answer, tell me. So, as I've told you, the blue one, which is your media, the middle layer. Oh, that is medial layer gets degenerated in a particular condition. And this degeneration leads to necrosis. This necrosis leads to destruction or dissection. Okay. And if it is on the aorta, it is called aortic dissection. Okay. So this necrosis, this degeneration can lead to some cystic space formation. Okay, this can lead to some cystic space formation in between in this layer, and finally leading to dissection, break. Okay, what happens is that there is a break completely in these 2 layers. Okay, and yeah, you see that your blood is flowing into that. We'll come to this. will form a false lumen, a separate channel for the flow of blood. So this is called aortic dissection. So all this is due to basically the cystic the medial layer get necrosed. Okay, and it is a very important feature, very important feature of Marfan syndrome, which we were discussing. Okay, so basically it is also seen in other conditions. Okay, especially now see, this is what one statement I saw, and I was a little perplexed by this, taken from your Sparsh Gupta. It says that, okay, it is explaining about your cystic degeneration. It is saying that this is seen in Marfan syndrome and scurvy. Scurvy is what? Vitamin C deficiency. I don't know if it is seen. I searched in different areas. I couldn't find that scurvy is associated. But then, if Sparsh Gupta is saying it, it should have some meaning. And scurvy is a very important lesion as dentists are concerned because it has got gingival bleeding, gingival enlargement, isn't it? So you good to know that. Okay. CNN. Okay. Medial degeneration. Okay. Now a little bit again associated conditions. Okay, so the answer someone said A, yeah, Marfan syndrome. You're right. So this is medial degeneration leading to dissection, aortic dissection. Okay. Now another question. Most common cause of dissecting hematoma, or other name is aortic dissection. Hematoma. Why are they saying hematoma? Because the blood is flowing into which color will I use? Okay, the blood, okay, red only. The blood is coming here and it is getting inside here. It is looking like sorry, it is looking like hematoma. So it is dissecting hematoma. So the most common cause of dissecting hematoma, what is the answer? Most common cause. Quickly. Now I know all of you will answer B, but the answer is A. The most common cause is hypertension. Okay, so most common cause is hypertension. Don't forget. Marfan syndrome is also a cause of it. As I've told you, Ehlers-Danlos syndrome. We saw, isn't it? There is aortic aneurysm, aortic. So if there is aortic aneurysm, there is also Ehlers-Danlos syndrome. Then in trauma, okay, and in Turner syndrome. So all these are associated with your aortic dissection. So don't forget hypertension. If you want to remember, first one is Marfan's syndrome. So if you want to remember a short form, it is MET, METT or MET. Okay, aortic dissection, don't forget. Aortic dissection is a complicated area of aneurysm. Please note this. Aneurysm is just a dilatation. Dissection is cutting in the blood coming out of it. So these two are two different conditions. The most common cause. Now, why is the dissection happening in hypertension? Understandably, the blood is flowing at a very fast pressure. BP is very high. It can dissect slowly by slowly, it can dissect. We saw why it is happening in Marfan's. What is that? What is the cause? Medial degeneration. Ehlers-Danlos, why? Collagen problem. Trauma can naturally happen. It Turner syndrome, again related to some genetic defects. Okay. So yes, yeah, this is a typical picture you can see here. So yeah, I think I'll use blue. So normally this is the blood flow. What happens is the blood flow. There's another false cavity being created. Okay, which causes the blood to flow into that. Okay, and leading to this particular problem. That is a pseudo lumen creation. Okay, yeah, this is it. Which one? This one. Okay, this one you can call it. Now, please note there's a condition where you will get the blood here. Okay, where your outer wall is also broken. Your outer layer is also broken. Adventitia is also broken, which is definitely will come to that. Okay, anything I'm missing out for you? No. Okay, so we said, yeah, popliteal artery is one of the causes of, okay, we'll come to that. Popliteal artery aneurysm is more commonly, it is basically aneurysm. So I should say that we should have discussed a question on aneurysm. Is it missed? Yeah, it is there. So most common cause of aortic aneurysm, we said dissection, which is break, but then initially dilatation should happen. Then only dissection happens. But we said the most common cause of dissection is hypertension, and Marfan syndrome is second most common. Okay, and MET is a Ehlers-Danlos and trauma Turner's. But then if we ask you most common cause of aortic aneurysm, what is the answer? Everyone wants to stick on to Marfan's, and that's why my purpose, when you see this, it's not Marfan's. It is atherosclerosis. You know what it is. Okay, the plaque buildup on the vessels. Basically, what happens in atherosclerosis is plaque buildup. This can weaken your vessel wall, and it gets dilated. So most common cause of aneurysm is, hope you all understood the difference between aneurysm and dissection. Okay, basically aneurysm is just a bulge. Okay, an enlargement or a bulge, you can call it. Okay, and yes, again, this is all connected. If you ask the causes of aneurysms, the most common cause, as I've told you, is atherosclerosis. Then if you ask me the second most common cause or the more common cause, again, it is Marfan's. Because aneurysm is leading to dissection only. We saw dissection is very common. But then hypertension is not a very common cause of aneurysm. Though it is there, it's not a very common cause. Again, Ehlers-Danlos is there. Ehlers-Danlos is also there. Okay, and one more additional lesion here, if you need to remember, it is Loeys, okay, diet syndrome. One of the option, I think, when we discussed on the WhatsApp, it is it. Loeys diet syndrome, Ehlers-Danlos and Marfan's. The other one was MET, so that was more into trauma and Turner's. The most common was hypertension for dissection. Now coming to aneurysm, the most common is atherosclerosis. Again, we have ME, but then slightly different here. You can call it as MEL if you want to. Okay, Loeys diet syndrome. Basically, we saw that Marfan's is a problem with elastin. Ehlers-Danlos is a problem with collagen. This is a problem of elastin and collagen. Okay, because it is affecting a gene, or I would say a receptor, TGF beta receptor. Okay, TGF beta receptor. Now, TGF beta receptor is a signaling molecule for the synthesis of elastin and collagen. So, if TGF beta is affected, you will get problems with the elastin and collagen. Here, basically, it's all about collagen gene affected. Marfan's, it is only the fibrillin. So, it's elastin related. Here, TGF beta, the more receptor is affected. You know that anything to happen in the body, there should be a receptor getting stimulated. So, this receptor is affected. You don't get your collagen. You don't get your elastin. So, you get all the problems associated. I don't go into details because no questions has been asked. So, we said, don't forget this. Most common cause of dissection is what? Hypertension. Second is Marfan's. Most common cause of aneurysm is atherosclerosis, Marfan's. Okay, at least two you remember, it is enough. Yeah, this is your okay. Aorta, abdominal aortic aneurysm is what you call it. Okay, okay. I'm not going into too much of details. This is your okay. This is another cause. MI is one of the causes. Okay, myocardial infarction is another cause where you get this aneurysm of your ventricular walls. Okay, should I go into details of this? I'll give you some terms, something to remember. Okay, so about aneurysm, the most common peripheral vessel. Okay, just write it down there. Some extra points about aneurysms. Most common aneurysms. So most common peripheral vessel to undergo aneurysm is here, as I've told you, it's a popliteal. popliteal artery. Basically, popliteal artery is something which is related to your knee. Okay, your knee. This is your popliteal artery, which is associated with your knee. Okay, so that's one thing. Now, yeah, I'll put it here because this is where, okay, this is the most common peripheral. Okay, then if you ask visceral, the most common visceral artery which is undergoing the aneurysm, this is splenic artery. Okay, the spleen, the artery which supplies the spleen. The most common central vessel which is undergoing aneurysm is something which you will learn in surgery also. Okay, central vessel is abdominal aorta. Abdominal aorta. So basically, what is abdominal aorta? You have got your ascending aorta going up, you have got your descending aorta. This descending aorta further comes down and gives rise to abdominal aorta. So basically, I should have been a little more correct here. You have got your descending aorta here. I'm sorry. Descending aorta here. Then you have got your thoracic, then abdominal. Okay, so this is the most common central vessel, just to know. Okay, people clearly, why I'm saying this is, they will confuse you. Most common central vessel, abdominal aorta, thoracic aorta, ascending aorta, descending aorta. Basically, it's abdominal aorta. And this is also the most common of any vessel. Okay, we said peripheral is popliteal. Okay, popliteal. Visceral is splenic. Central is abdominal. But the most common in any case, it is abdominal. Just an extra point to note. Okay. Yeah. This is another thing which you should be aware about. So just to teach you a little bit of basics here, but did I miss any question? No. Okay. On aneurysm only. So basically, this is what I was talking to you. Your three layers, adventitia outside, media in the middle, intima. So what you have got true aneurysm. There's a possibility. There's a false aneurysm, and there is also dissection. Okay, true aneurysm can be saccular, can be fusiform. Very simple to understand. It's in the form of a sac here. This is both the sides are enlarged, fusiform. Okay, so hope if you understand the major differences between this, I'll tell you what is the technical difference or the structural difference. Basically, aneurysm is just a bulge. So you get a bulge on one side or bulge on two sides, and there is no break in the wall, except we'll see it in the false aneurysm a little bit. Okay, no walls are affected, walls are intact. Okay, but then as I've told you, in your dissection, your intima gets problematic. The blood leak into your media, but it is very clear here that your externa or adventitia is intact. Okay, now what happens in false aneurysm? The blood leaks out outside the vessel completely. Even your externa is also, or adventitia is also broken. The blood comes out and is in the extravascular connective tissue as a bulge. Okay, so it's a kind of hematoma again. False aneurysm. Okay, false aneurysm. So that's the difference between true aneurysm, which is again it is just a bulge, the blood is inside. Dissection, yeah, still you have the outermost layer intact. False aneurysm, basically the blood is in the extravascular connective tissue. We feel it's an aneurysm, but actually the blood has leaked out. Okay, so just an extra thing to know. Okay, because otherwise, why so much pages? Am I missing on anything? So this I need. That's why I told you yesterday. I need this reference. I can teach you, but then if I miss a lot of points, it is you who is going to miss out. Nothing. They just left a lot of pages. Yeah. So we said about dissection aneurysm. So calcification is the next question. What's the question? We saw all this. So calcification of the aortic valve is seen. That's the answer. You're reaching 1 hour mark, but then we'll quickly. It is not Ehlers-Danlos. You are expected that after Marfan's, we'll jump on to Ehlers-Danlos now, but I'm going on to syphilis. Okay, very good, Parvati. Very good. C is the answer. Okay, syphilis. Basically, calcification of the aortic valves are seen in two infections. I want you to tell me, when we said about syphilis very recently, what was that in syphilis we saw? Along with Ehlers-Danlos and Marfan's. What was it? Retinal detachment? No, Baba, no. No. Aortic aneurysm in the beginning. Aortic aneurysm, very good, Banjo. So aortic aneurysm, please note, is also seen in syphilis, tertiary stage of syphilis. Aortitis, you'll learn this. Aortitis and aortic aneurysm. I think there's also short form flu and the cardiac lesions there. But just to connect again. So aortic aneurysm, we saw it is there in MEL. No? MEL is the one. Along with that, just write S also. MELS. Okay. Or smell would have been the better short form, I guess. Yeah, wonderful. Smell. Right there. Smell. So S is for syphilis. But don't forget, the most common is atherosclerosis. The second is Marfan's, not syphilis. But now coming to calcifications, that is seen in two lesions. Calcification of the article. Now, you might be saying that this is all something to memorize. But then whenever you see most common, it can asked as a clinical question. For example, they will give you some features of syphilis. And what is one of the features? Shankar. Shankar. But then something will confuse you. What is that? Calcification of the aortic valve. They'll say that it's a sex worker or something like that because it's a sexually transmitted disease. So basically, the most common is always important. Okay, the terms most common. They can ask you question. How do you learn it? Revision. Okay, so calcification of aortic valve is seen in syphilis. One more condition, which is again an infection. Okay, let me take that page. Yeah, it is basically rheumatic fever, where we saw what type of murmur connection. What type of murmur in rheumatic fever? So two conditions where you see calcification of aortic valve is one is syphilis and second is rheumatic fever, which is a streptococcal infection. Pansystolic, exactly, Manju, very good. You people are listening. So basically, why? Because it's an infection. No? Both of them are infections. So basically, there is inflammation and scarring. Scarring leads to calcifications. Okay, so just remember, calcification is more common when there is aortic valve is infected. Wonderful question. Okay, it's a medical question also. 26-year-old, don't look at the keyword, just read. Okay, something comes to your mind. Presence because of trouble with her vision. Many lesions are there. I'll show you more. Physical examination, very tall, thin woman. Okay, now still you can't come at a conclusion. Please note, very tall, thin woman. Maybe sometimes you people think that, okay, it can be even be your gigantism, acromegaly, isn't it? With long, thin fingers, again, it's pointing towards your Marfan's. Examining her eyes reveals the lens of her light eye to be in the anterior chamber. Displacement of the lens. Her blood levels of methionine and cystosin are within normal. So this is saying that it is not methylcystinuria and all this. Okay, that's not significant. Is there any option? No, forget it. Which of the following is most likely? This is just to confuse you. Methionine, cystathione and all. Most likely diagnosis. No, you have to, for this particular question, you have to a little bit connect with the option. When I'm saying D, don't jump onto GD. Wait. Connect the option. Copper metabolism, definitely not very severe. It will not lead to some lens problems and all. Vitamin D, again, there is no problem. Lysyl hydroxylase, decreased lysyl hydroxylation of collagen. Isn't this an Ehlers-Danlos? Defective synthesis of fibrillin. defect is in this of type 1. Basically, it's very clear that here the lens is displaced. D, okay, there's E is also there, I'm sorry. Lens is displaced, very tall. So lens, the moment lens come to your mind, some lesions do come. One of the lesions I'll show you, but then the moment lens comes, it is your Marfans. Now very clear, very tall, thin woman, because in acromegaly and gigantism, you don't have any problems with the lens. Okay, so the answer is yes. Okay, this is what I was saying, the picture. This lens, okay, this is a lens. This is displaced into the anterior chamber of the eye, or the vitreous humor, slightly anterior into the anterior region of the eye. So it is get displaced anteriorly. It can also get displaced posteriorly, also into the vitreous body. Okay. So yes. Okay, this is a wonderful question. Which of the following gastrointestinal polyp syndrome is associated with congenital? This is asked for you. Congenital hypertrophy of retinal pigments. Congenitally hypertrophy of retinal pigments. There should be very clear key is there. Gastrointestinal polyp syndrome, which is definitely Gardner syndrome. But then please note that there is a retinal. The other one is retinal displacement, and lens is displaced, retina is displaced. So basically a retinal detachment. Here it is hypertrophy of retina. Okay, Gardner syndrome. What is the key lesions associated with Gardner syndrome? Eye is definitely the congenital hypertrophy of the retinal pigments. I think that is okay. This is all right. The question is, yeah, this is basically I'll show you a bigger picture. This is basically the retina, the yellow region, okay, where the light falls and you get the vision. Okay, so if you just enlarge that part, you have got your little retinal pigments, the rods and cones. Okay, so that gets hypertrophied. That is one of the lesions. What are other lesions? What are very common lesion? Polyps, the cell polyps. You get multiple supernumerary teeth. You get osteomas. You learn this in your oral pathology, but then when you learn it, connect it. Okay, epidermolysis, desmoid tumor. Okay, I'm not going into details of that. Otherwise, your time will consume. Now, another eye lesion. Okay, now this is another question. Again, I need you to read it, identify the key point, which will click you, and then answer it. A female patient, again, it's not significant unless you find the key point. Okay. Presents to ophthalmology clinic, again, complaining of chronic redness, irritation, and tearing in both the eyes. Tearing means it's a tear, this tear. For the past several months, she also reports of difficulty in opening her eyes in the morning due to sticky eyelids. Very typical feature, but I'm sure you will not recognize this as of now. Let's leave it. On examination, the ophthalmologist, this is it. Adhesion between bulbar and palpebral conjunctiva is known as symblepharons. Bulbar and palpebral conjunctivas are joined, the two conjunctivas. Okay, this is it. Yeah, this is the one which is in this area. This conjunctiva is called the bulbar conjunctiva. This is your palpebral conjunctiva. Okay, so these two joined, and patient cannot open the eyes if they have this problem. And also there is inward, okay, I'll use the same yellow color, inward turning of the eyelids, which is called entropion. The biopsy with, okay, this is all not very significant. A biopsy with direct immunofluorescence seen shows linear deposition of IgG and C3 on the basement membrane zone. Okay, how many of you are there? Okay. On the basement membrane zone. This is the key. This is going to give you the key. It's key. The moment you see basement membrane zone, please note, deposition of antibodies and complements, antibody IgG and complement, any antibody, at the basement membrane zone, the most common lesion you have studied will be pemphigoid. Please note. Look, I'm teaching you how to identify this. Pemphigoid. Okay, and second thing is Pemphigoid can be mucous membrane pemphigoid, can be the cicatricial pemphigoid. Okay, or I would say bullous pemphigoid, which is there in this option. Yeah, bullous pemphigoid and the cicatricial pemphigoid. And please note, it is the cicatricial pemphigoid which has got, isn't it, eye lesions. You don't get eye lesions much in the bullous pemphigoid. Okay, so this is how you identify for this particular question. Okay, cicatricial pemphigoid, eye lesions are more common than your bullous pemphigoid. Now, so you have clearly identified it, so you can clearly eliminate this part. It is not bullous pemphigoid. Now, you ask me, what about pemphigus vulgaris? Doesn't it have eye lesions? Definitely, it has got some eye lesions, which is different, and which doesn't have symblepharons and entropia. Okay, so that's one thing. And another thing is, where is the what do you call antibody seen? Isn't the basement membrane zone? Someone? Suprabasilar split. So that is above the basement membrane. You have the epithelium. Okay. You have the basement membrane. You have the, below that, you have got the connective tissue. So this is your epithelium. You have your connective tissue here. So what they're saying is in the pemphigoid, it is the basement membrane zone. Whereas in your pemphigus, the antibodies are seen here in the epithelium. It is suprabasilar split. Nikolsky sign positive. That's a very good feature of pemphigus vulgaris. So again, they're not talking about your, Nikolsky sign and all. Nor they're talking about suprabasilar split. So again, you can easily eliminate your pemphigus. Okay, pemphigus vulgaris. Dermatitis herpetiformis, basically it is something where you have got your skin very pruritic lesions. Okay, pruritic lesions, and it is IgA mediated, not IgG. So again, you can eliminate that. Linear IgA disease, again, it is an IgA mediated. This one we already eliminated. Sorry, on this one, there was the answer. The bullous we had eliminated. So this is eliminated, this is eliminated. Finally, the answer is cicatricial. So please note, you can't arrive at a particular answer connecting everything at one go. Find out what you can connect. So basement membrane zone immunofluorescence, basically immunofluorescence is a key for pemphigoid, which has got two types, bullous and cicatricial. Cicatricial is more common with the eye lesions. Your answer is done. Okay, anything else I'm missing on? No. Okay. Before going on to anything else, do you know any other lesion which has got any other condition which has got eye lesions with with your salivary gland lesions? Any lesion which is salivary plus eye? Zika syndrome, or yeah, Sjogren syndrome, where you've got lacrimal glands being affected. So that is lacrimal glands affected. Keratoconjunctivitis Zika. Okay, dry eyes, dry mouth. So I think that will be the end of it. Yeah, Sjogren syndrome is also there. Okay, next question is, so we'll come to the next day. So I'll stop it here. I think I'll just give you, are you ready for a small discussion on things? Because today I got a message from a student saying that, okay, let us discuss it here. Saying that, sir, I am being ignored, made fun of, insulted by people around me. What will I do? Because I'm not doing PG, nor I am having, my income is low because I'm not working. So I'm being insulted by my, when I go to marriage or when I go to my relative's place or somewhere. Okay, or whatever. How many of you have faced this issue? Raise your hands. I'm sure everyone would have faced, and some people are not going to respond for anything. Thank you. Those are raised. Good. Don't worry, I'm going to name you. Okay. But you can raise your hands so that let me know that is it worth discussing or not. Or I'll just leave it. What is the solution for it? This is what I'm going to talk. So if you raise the hands, I'll come to know that how many are facing. So is it worth? Or I'll just skip it. And we'll go for the next day tomorrow. Okay. Fine. So it's worth discussing. I saw some good number of people raising their hands. No, see, basically, to be very frank, I faced it when I was preparing. But actually, it is kind of a feeling more than facing, because we all feel that people are ignoring us, people are creating problems for us, or they are insulting us, kind of things. What is the solution for it? See, the solution I find, now see, it's not about you are, preparing or not. Whether you're preparing, wherever you go, some people will be there who was there to scratch you, insult you, to say something because they just love it. So, what is the solution for it? What should you think on that? How should you ignore that? See, basically, the typical example I'll tell you for you to understand this is this person who is insulting you, who is making fun of you, is one among the millions of creations in the world who Almighty God has created. You have to be a believer for you to understand this. Almighty God has created to influence you, or to interact with you on a particular day. On a particular day, Almighty God has designed that this particular person is going to come to your life. Okay, is going to come to your life and is going to influence you in one or the other way. Okay, so now it's just one among the millions of creations. So first thing you have to keep in your mind, this one among the million creations should not influence your life at all, your success at all, because this person, even if he's very talented, even if is one of the highest paid person, just think that just among one among the million creations who is not worth with millions of people around the world. He might be a good person, but then definitely there are a million more people who are more influential, more powerful than him. So it doesn't worth to be dictating your success in life. One. Second thing is, if you ignore this person, as I've told you, this person is coming to you in your life, destined to just influence a particular moment in your life or some particular moments in your life, if at all. If you allow that person to stay there, how do you allow the person to stay there? You argue with him. You say that you try to explain to him, and he's 100% sure he's not ready to accept it, or he don't want any argument against that. He want to just scratch you, so it doesn't matter to him, even if you argue with him, if you want to explain to him. So now, if he's coming and is influencing your particular life for maybe 1 minute 30 seconds, or maybe, okay, let's take it as 5 minutes, even to the extreme, you just leave it. You remove the influence of this person further. Instead, you argue with him, you think on it, what you're giving space to him. Do you agree? How many of you agree? You're giving space to him to influence more than God has destined to. For example, God has destined to influence or destined him to influence you for 1 minute or 2 minutes. You argue with him for 10 minutes, you make his influence for 10 minutes. Is it worth? Very important thing you have to think in your life, the entire. I'll give you a typical example. You drive your vehicles. Now everyone is driving, so you'll be experiencing it. uh, and someone comes and in a wrong way and try to just hit you, and maybe something like, or he shouts at you. If you just ignore him and smile at him, go, that is over. You shout at him, you shout bad words at him, he stops the car, he comes out, he shouts at you, you shouts at him. Isn't your life influencing more by him? Agree? How many of you agree? Raise your hands. Yes. So this is the key. This is the key for a peaceful mind. Don't allow these negative, toxic people to be a part of your life or part of your space for more than what is destined normally. Please note, what is destined normally? Any explanation, any argument, anything is just waste of time. Now, 5 more minutes, I'll close it. How many of you agree, or how many of you know about your, I'll just lower your hands. How many of you know that about YouTube algorithm? How many of you know about YouTube algorithm, artificial algorithms, artificial intelligence based YouTube algorithm, or whatever? How many of you know it? Raise your hands. No idea? Oh, come on. We are the modern technology 21st century world. Basically, you might have seen that any video you're watching, you will see that after that, that type of videos continuously come to your YouTube, your mobile phone, YouTube. Below that, for example, you're watching a particular actor's movie, you'll see that it'll keep on coming. For my case, I watch a lot of cricket. I see lots of cricket videos coming. If you're watching entrance preparation related videos, you will see all the entrance preparation coaching videos coming. This is called algorithm. This is where the YouTube sets automatically, they're not sitting there. They set artificial intelligence based algorithm, which is setting based on what you see, what you buy, what you look, what you search for in the internet, everything. Okay, understood? Understood this? This is very important for you to understand the next concept, which is related to this. Understood or not? Yes or no? It's an automated setting of algorithm based on what you do on YouTube. Understood? Trust me, this exactly applies to your real life. Maybe YouTube algorithm has come 4-5 years back, but the human algorithm has been there since day one of creation of the world, or I would say not world, humans. What is that? What you do sets your algorithm in that direction. Okay, now you fight with a person, you are influenced, your life is, or you keep fighting with a person, your algorithm in life is set in that direction. You'll always be disturbed in that way. That person will be there in a part of your life, his life or her, your life. Keep coming. People like him comes. Okay, you get irritated, or you have got prejudiced approach towards people like him, or you're thinking that people are like him, like her. Okay, so this algorithm is set when you go in a negative side. This is very important for you in your life. Please keep this in your mind. This is very important in your life. Not just entrance preparation, but very significant in entrance preparation. You're doing something good, your algorithm is automatically set in this direction. That's why I tell you, respond, because the algorithm is getting set. You don't know it, your subconscious mind is setting it. Forget about response. You are being influenced by something wrong. You do something wrong. Your algorithm goes in this direction. You feel depressed because the moment you are influenced by a toxic person, you see that toxic people around you. Okay, I've always wondered why is that some foreign countries, they just keep going up, and uh, some countries are always in an underdeveloping state. That's all this. People around there. So you are going in the wrong direction, you will find wrong people. You're going in the right direction, find the right people. Okay, so make sure that you don't allow any space for toxic people in you. Now, see, when I'm saying this, don't misquote me on your feelings. Okay, many a time it's our perception that we have the wrong feeling that this person is ignoring you or this person is misbehaving with you. That is your thought also. That's another possibility. If you don't react, so this is, I've always experienced this. I've always experienced this. Many times you feel that this person is a little negative, toxic. Am I right? Is it this person a little toxic? And I say, okay, fine, I'll apply this particular principle in life. I don't react to him. Let's say. After 2-3 meetings, we try to understand that it is basically just because that our thought process was wrong, this person was right. Again, it's all about not reacting or just keeping yourself calm under initial go. Now, if the person is coming and disturbing you again, let him go. Okay, I've always said this or tell this. People in your first circle, your family members, they might irritate you, but then that irritation is acceptable. Your spouses also comes under that. Then your relatives and your first cousins, your even your spouses, sorry, your brothers, sisters comes there. And finally, you have got your relatives, outer relatives, the people you meet in the marriages comes there. So I would say the first circle is where you give 100% space, whatever happens, because that kind of discomfort should be there. That is a part of life. You can't. Second, you have to go for a selective. Third, no space. Whether toxic, non-toxic, no space. Okay. So I hope this helped you. This is very important. And always think that don't give space to, or don't give more space than that person is destined to the moment you feel that it is toxic. Maybe it's your perception that person is toxic. That's also a possibility. Maybe that person is actually toxic. In either case, don't give so much space, or don't argue, or don't discuss. Let the time pass by. Maybe you'll realize that that person was not toxic. It's a good thing. Maybe that person is actually toxic. Still, it's a good thing because you didn't give space and it is just went over. Okay, all of you? I hope this helped. So thank you so much. Have a great, wonderful day, and take care. Keep revising. You have got your second exam. I hope all of you have done your prosto exam, complete denture exam. Thank you, all of you. You've done your prosto complete denture exam. Make sure that you're doing it. Okay, and yes, you're learning it. It's just how calm you keep. Okay, and how positive you go, and how much effort you put. That's it. The rest all will happen. Okay, all of you. Bye and take care.